Good evening, everyone. How are you all? Welcome to First Aid AMC MCQ free 2-week session. So, as you are aware, tonight is our recent sample question solve class. And as we have been discussing that some of our classes are based on theory session, some classes will be on sample question solvation. Some classes will be mainly related to, let's say that after finishing a theory session, we will just go through your question solvation on that particular theory. So this is usually our type of the classes that you are going to get. So you did theory session with me, you did a question solvation class with me. Tonight's session will be with Dr. Rabia. She is also one of our mentors, and she is very well loved among all of our candidates. And since she has joined the course, the number of students, the passing candidate has got significantly improved. So obviously she has a lot of things to give to you. Okay, so I hope that you will enjoy her session. And she also passed her MCQ and clinical examination within very short period of time. So I hope that you enjoy the session. I will give this session to Dr. Rabia, and I will be here if you need, but most of the questions will be answered by Dr. Rabia tonight. If you have any questions about the course, you can always ask me in our next session, which will be on cardiology question solve. Okay, so enjoy the session. Dr. Rabia, the class is yours. Thank you.
Thank you so much for such a wonderful introduction, Dr. Arshan. Good evening, my dear doctors. My name is Rabia, and as Dr. Arshan told you, I have been a student of first aid myself, both the AMC MCQ course and clinical course, and I passed both my exams in my first attempt. So this course played a vital role in making the base that I have today in order to work in the Australian health system. Now, as Dr. Arshan already mentioned to you guys, I will be taking the question solvation classes in the course, and we have a class every week on Wednesday, 7:30 Sydney time. And in those classes, we will be going through recent questions which are coming in the exam, and we will discuss the topics in detail which are being asked frequently in the exam. And I will be helping you guys about the tips that you need in order to quickly look at the question, quickly look at the option and to choose the best option among them. AMC MCQ exam is not too difficult, but it's not too easy exam. You just need a very good base in order to pass the exam easily. And we are here to help you with that. AMC MCQ course is a full package. You have theory classes with Dr. Arshan. You will have relative questions relating to that topic by Dr. Arshan, and I will be helping you guys with the most recent questions and the topics which are coming in the exam. So I hope we will be together in this journey, and we will help you guys to share your dream of working in an Australian health system. So let's start. Please do let me know by one of the participants in the chat box that are you guys able to see my screen? Just let me know in the chat box. So usually what happens in the class that thank you so much, everyone. Wow, that's a wonderful response. Thank you so much. So what happens usually during the class, we don't turn on the mic while I'm speaking because it kind of disturbs the rhythm. So I will really appreciate and would really encourage you guys, if you have any query regarding any questions that we are going to go through today, please ask them in the chat box. I will look at the chat box. It's in front of me all the time. I will be looking at your questions and I will try my very best to satisfy you, okay? So let's start. Okay, the first slide is about the sources that we use for the exam. That's very important for you guys to know. So much more important is this book, John Murtagh. It's the latest edition. I think the 8th one is in the has been published. So this is your base. Just like in your own medical school, you had a big book of medicine. This is the big book of medicine, surgery, gynecology, pediatrics, and population health in Australia. And it's taught in Australian med schools, right? So you will be provided with this book. You will have an access to this book and you will be able to download it in PDF. Dr. Arshan will give you all the resources. The next one is the websites that we will be consulting during our finding of the correct answer in our questions. So this is the RACGP, which is Royal Australian College of General Physicians Club. Then there is RCH, which is the Royal Children's Hospital website. SA Health is the South Australian website, and they are this website I have always consulted and advised the students to please, if you're studying any case of obstetric, then please go to this website. They have all the topics and everything that you need to know about obstetrics and gynecology. This is the site I would always advise you to go. Health Direct, we will be consulting. This is also one of the websites. NSP is a website that is more associated with acute presentations and the emergency department. Queensland Health will also help us, and Victoria Health. Now, other than these two, I also sometimes consult the Kaplan and MedBullets, which is the website of the USMLE books. Okay. All right. So I hope that is clear to you guys. Some other sources that I also use, all the links will be given in your software about which topic has to be studied from where in the PowerPoint presentation that is uploaded in your software, which you will have access, of course, after joining the course. And you will have the access till you pass the exam. So don't worry, take your time, have a good course, and then prepare for the exam to pass it. All right, so let's discuss. These are the November recalls that we are discussing, because in December, usually there are, I think in the first week after that, because of the holidays, there are no exams conducted until February. So these are the latest November recalls that we're going to discuss today. The first question is, so I will be helping you guys to point out what are the most important things that you want to look at a question. All right, so very important is that whenever you study a question, look at the age, look at the presenting complaint, and what have they asked us at the end of that question. That is the main point. So here, a child of 6 years presented with 1-day history of acute earache and high-grade fever in the emergency department, right? Very important information has been given. You are an intern on duty. What do you want to do next? So this is very important that you study this line, the last punchline of the question, very carefully, because it's going to determine whether your answer is correct or not. Okay, so always look at what they are asking. What is their wording? So they have asked here what to do. Option A they have given is IV antibiotics. Option B, analgesics with or antipyretics. Option C, oral antibiotics. Option D, admit in the hospital. So can anyone tell me, a 6-year-old child with 1-day history of earache and fever, what is the diagnosis, that is provisional diagnosis, that is coming to your mind? Can anyone let me know in the chat box? Very good, Dr. Gaya. So this is acute otitis media, right? Because this presentation is acute and earache with fever is indicating an infection, that is most likely acute otitis media. Now the patient has come to the emergency department and you are a doctor on duty at the moment. What do you want to give to this patient so that the patient settles down? Option A, do you want to start with the IV antibiotic right away? Option B, do you want to give analgesics and antipyretics? to settle down the fever and the ache the patient is having in the ear? Option C, oral antibiotics. Option D, you want to admit the patient in the hospital. All right, so we are having an answers that is a tie between the two A and B, right? Oh, sorry, B and D. So we know that we don't want to start IV antibiotics in this patient straight away. So we know this is not the criteria for it, right? Some are saying B, some are saying C, and majority is saying D. Now, admitting in a hospital of a 6-year-old child, there are certain criteria that are followed that are the red flags, right? The patient is just having a fever and acute earache. The patient is not having signs of sepsis. The patient is not deteriorating. The patient is not requiring an inpatient treatment. So admitting in the hospital at this time is not required. Now, as we know, this is an infection, but according to the guidelines that have been given, acute otitis media, if there are no red flags present and presenting with a short history, the first thing that we give is analgesics and antipyretics to the patient. And most of the time, the symptoms settles down with just antipyretics and analgesics. We don't need to start the oral antibiotics for that. Okay? There are certain conditions in which oral antibiotic is the first line. Let us discuss those along with the whole topic. Now, let me increase the size of my screen so that you guys are able to see better. If you look over here, if you look over here, this algorithm I have taken from the RCH guideline. If you just write in your Google box, okay, let me show you how to search for it as well so that you guys are aware about how to search for an answer as well. Okay. All right, so if you open this part and you write acute otitis media, RCH, then a guideline like this will come. Clinical practice guidelines regarding the acute otitis media. Are you guys able to see the screen where I'm opening the Royal Children's Hospital Melbourne's guideline? All right. So this is how you study the topic from Australian guidelines, right? So what are the key points they want us to understand in this topic? That they're saying that do not accept otitis media as the sole diagnosis in a sick febrile young child without exclusion of more serious causes, right? So in a if the patient is just presenting with a fever, you have to rule out other causes of infection as well. If the infection is in the ear, there will be earache, ear discharge. There might be signs of upper respiratory tract infection. There can be pneumonia. It can be a gastroenteritis. It can be because of the urinary tract infection. It can be severe diseases like meningitis as well. So we need to have other differentials as well if the child is just coming with the fever. Diagnosis require acute onset and an abnormal ear examination with the signs of middle ear inflammation and middle ear effusion. These are the criteria for the diagnosis of the acute otitis media. I'll show you guys further in the website. They have given a picture that clearly describes what an inflamed acute otitis media ear looks like. Avoid the routine use of antibiotic treatment for acute otitis media, right? They have clearly mentioned, this is one of the key points, that this is not the first line treatment for acute otitis media. We always start with analgesics and antipyretics, and there are certain cases in which antibiotics are recommended. Very common in the school age group and also in the 6 to 18 months. History will be recent ear pain, fever, loss of appetite, vomiting, lethargy, might be patient immunocompromised or having a cochlear implant. So these are the risk factors they have mentioned in the red blocks. On examination, patient is systemically unwell, fever will be there. or ear examination with the help of an otoscope, the tympanic membrane will be red bulging. And if it is accompanied by suppurative infection, there will be air fluid level of the pus as well. So this is what a normal tympanic membrane looks like, right? It's translucent. You can see the light of the otoscope is reflected. The handle of the malleolus is vertical. But in an inflamed one, it's all red and the handle is a bit on the horizontal side. The suppurative one, you can see bulging of the pus inside the middle ear. And the one with the effusion, you can see that it is having bulging property along with the amber fluid, right? And this one, this is a perforated one. You can see a big hole in the tympanic membrane with the discharge coming out of it. And this is the external part of the ear, and this is otitis externa. You can see there is some pus in the external ear canal, along with signs of inflammation. So what are the treatments? So let's go back to our slide that's going to help you guys. Okay, if the patient is mildly unwell and there are no red flags they have given on the right side, not less than 6 months, patient is not immunocompromised, patient does not belong to Aboriginal or Torres Strait Islander. These are the people who are the original owners of the Australian land. They are known as Aboriginals or Torres Strait Islander. They have only one hearing ear. They have a cochlear implant or some suppurative complication. If none of the red flags are present, then you will just give analgesia and no antibiotics for the first 48 hours. If the symptoms are improving at 48 hours, then you advise the parents to seek medical review if a patient is still having some ear symptoms after 2 to 3 months. So you have to have a follow-up with the GP. But if the patient's symptom is not improving after 48 hours, then you start the antibiotics, which is amoxicillin for 5 days, twice a day. And still not improving, then you can give amoxicillin with clavulanic acid for 5 days. But if the child is presenting with red flags, that is less than 6 months, immunocompromised, Aboriginal, Torres Strait Island children, only hearing ear, has cochlear implant, then with the analgesia, we start the antibiotics. Okay? Is it clear, everyone? All right. So other than the patient who are having penicillin sensitivity, hypersensitivity, you can use cephalosporins, especially cefuroxime. All right. And if still you can't give cefuroxime, you can give trimethoprim sulfametazole as well. So these are the 3 antibiotics that are recommended. All right, let's move to the next task. Next question is, a patient who is 26 years of age presented with upper respiratory tract infection with 1+ proteinuria on dipstick and 1+ hematuria. She came back after 2 weeks for the follow-up. Everything you have noticed on the examination is normal. What do you want to do next to this patient? Reassure the patient? Do ultrasound of the kidney? Do urine analysis again? Or do the renal function test? So we all are agreeing that we will do urine analysis. Can anyone give me justification for why we are doing it? Why we need to do urine analysis? Very good, Dr. Rojas, because we want to recheck if the patient is still having proteinuria and hematuria, right? Upper respiratory tract infection with proteinuria, hematuria, we want to make sure the patient is not developing IgA nephropathy or PSGN. All right, prostreptococcal glomerulonephritis. So we need to make sure the patient is not having any nephritic symptom, so we will do a urine analysis in that patient. Reassurance, if this urine analysis is normal, then reassurance is the first thing that we'll do. If the urine analysis is abnormal, then we need to do further investigation, like whether there's any impact, any problems with the kidney itself. So we will do renal function test, or if there is any structural abnormalities on the kidney, so we can order an ultrasound of the kidney. Not necessary, Dr. Devi. If everything is normal, we still do the urine analysis just to be on the safe side, because PSGN can have proteinuria, hematuria, and it develops insidiously. So we need to make sure the patient is all right and nothing insidious is going on, or persistent hematuria. It requires further investigation. All right, so this is the correct answer. Very good. So you can follow this RACGP algorithm for it, right? If hematuria is there, urine microscopy and culture, then you have to do next, right? If positive, then treat the underlying infection or other underlying cause. If you can't find any urine microscopy culture in hematuria, in the urine microscopy and culture, there are no signs of infection, but hematuria is there on urine analysis. The next thing that we do is CT-IV pyelogram, or we do ultrasound with the urine cytology. Urine cytology means urine analysis, guys. So we will do urine analysis first, then ultrasonography. If we have found on ultrasonography there are some renal stones or ureteric stones, then we need to see what is the size of it, or whether it requires any surgical intervention. Then we need a referral to the urologist. If we find out some ambiguous things like urolithial malignancies, then we need a referral to the urologist and for endoscopic investigation along with the treatment plan. Hematuria does happen in benign prostatic hypertrophy and strictures. So if after doing the urine analysis and after doing DRE, you find that it is because of BPH, then you need to refer to the urologist for treatment as well. Urine analysis doesn't include culture. Urine culture and microscopy is for infection. Urine analysis is cytology. Is it clear, everyone? All right. So next question, no worries. A man in the 50s complains of numbness in the feet, 50 years of age. He can't walk in darkness because of some balance problem as well. He is strictly vegan and he looks pale on examination. Which investigation will you perform to reach the diagnosis? Option A, vitamin B12 level. Option B, CT scan of the head. Option C, MRI of the brain. Option D, nerve conduction studies. Option E, anticholinesterase antibody. Very good, everyone. So you know this is something associated with the neurological signs as well as hematological signs, right? And they have given you big clues. The patient is vegan and looks pale. So you know it's a hematological as well as a neurological disease. Can anyone tell me what's going on in this patient? Can anyone tell me the name of the disease? Vitamin B12 deficiency anemia along with peripheral neuropathy. Very good, Dr. Sarah and Dr. Roha. Very nice. So this is complications associated with the vitamin B12 deficiency. As the patient is strictly vegan, there is no meat in the diet, and the patient is not taking any supplementations. So it has led to vitamin B12 deficiency. Vitamin B12 is involved in the hematological processes of the red blood cells. That's why it's causing anemia, most likely megaloblastic anemia. And it is involved in the excuse me. It's also involved in peripheral nerve conductions. So it is causing peripheral neuropathy as well. We call this condition, it worsens, we call this condition as subacute degeneration of the cord. Very well done. All right, so why we don't do CT scan? Because patient, they have given us big clues. It's not just a neurological problem. The hematological sign and symptoms have been given. So CT scan, MRI brain is not necessary. If it was just peripheral neuropathy, like in diabetic one, then we might do nerve conduction studies. But here, the initial step of investigation to reach the diagnosis is to measure the vitamin B12 level. Anticholinesterase antibodies are measured in myasthenia gravis, so it's not necessary here. There is no descending paralysis going on here. All right, so we was this has been written rather nicely in the Med Bullets, which is USMLE website. So if you look, let's look, have a look over here. All right, so let's look at this picture first. So we know anemia is of different types based on the mean corpuscle volume. If it is less than 80 femtoliter, it's microcytic, which includes iron deficiency anemia, anemia of the chronic disease, thalassemia, sideroblastic anemia, and lead poisoning. If it is normocytic, the MCV is between 80 to 100, and it's of two types. Hemolytic, which has two other categories, intrinsic, including hereditary spherocytosis, paroxysmal nocturnal hemoglobinuria, G6PD deficiency, pyruvate kinase deficiency, sickle cell anemia, and hemoglobin C disease. While the extrinsic one are microangiopathic hemolytic anemia, macroangiopathic hemolytic anemia, and autoimmune hemolytic anemia. Whereas the non-hemolytic ones are the same as the microcytic ones, along with the aplastic anemia. Now, the macrocytic ones are those with the MCV more than 100 femtoliter, and it includes megaloblastic and non-megaloblastic causes. The megaloblastic is folate deficiency or folic acid, vitamin B12 deficiency, copper deficiency, orotic aciduria, not very important for your exam, but drug-induced by allopurinol. All right, and the non-megaloblastic are the alcohol-induced disorder, liver disease, and diamond black fang anemia. So these are the important causes that you should be aware of. So they have given a very good example of the vitamin B6, B12 deficiency here. A 55-year-old man is brought to his primary care physician by his wife for increased confusion. He forgets to turn off the stove after cooking and frequently misplaces his keys. He fell approximately 1 week ago while walking in the dark. His physical examination is notable for impaired short-term memory, decreased vibration and proprioception sensation, and patellar hyperreflexia. All of these are the signs and symptoms of vitamin B12 deficiency. On lab investigation, he has macrocytic anemia, reticulocytopenia, and low serum vitamin B12. All right. So it can cause megaloblastic anemia, the deficiency of this vitamin. It can cause a reversible dementia. It can cause subacute combined degeneration as well. So there are certain causes. Either you're not taking it enough from the diet, so a strict vegan diet, breastfeeding in a vitamin B12 deficient mother, and decreased animal product intake or meat intake is the cause of it. Or they can be other causes like decreased absorption from the gut because of the GI surgeries, like bariatric surgery and gastrectomy, or chronic illnesses of the gut that leads to impaired absorption, like Crohn's disease, celiac disease, pancreatic insufficiency, Diphyllobothrium latem, which is a tapeworm infestation, gastric atrophy. There are some medications which impair the vitamin B12 deficiency and are very important for your exam. Proton pump inhibitors, histamine receptor antagonist, metformin. Autoimmune disease like pernicious anemia can also cause it. Presentations, anemia, GI can cause glossitis. Neurological will be cognitive decline. On physical examination, you will find in your neurological examination signs and symptoms of the subacute combined degeneration of the cord. If lateral corticospinal tracts are involved, it can lead to weakness, spasticity, hyperreflexia, which is the upper motor neuron signs. If dorsal columns are there, then dorsal columns are involved in proprioception and vibration, so there will be gait difficulties. If spinocerebellar, again, gait difficulties, coordination problem, and decreased proprioception. So the first thing is that we check the vitamin B12 level. We also check folic acid level. We sometimes do serum methyl malonic acid and homocysteine levels as well. If you're suspecting it to be a cause by pernicious anemia, you need to do the antibodies level and anti-intrinsic factor levels as well. On peripheral blood smear, you can see there is hypersegmented neutrophils along with the megaloblast. So can you see, appreciate the hypersegmented neutrophil over here. Differential is the folic acid deficiency. Same symptoms, but no neurological manifestations. Treatment is that we start with the intramuscular vitamin injections after 3 days for 2 weeks and then bi-weekly. All right. Okay. Any question regarding the vitamin B12 deficiency, guys? Any queries in this question? All right. Another question is, a man came asking about prostate disease. He had symptoms of urgency, meaning he had to go to washroom regularly, and also urinary obstruction. He had difficulty emptying his bladder. Digital rectal examination was done, and a moderately enlarged prostate gland was found. The next most appropriate step of management in this patient is tell him about the pros and cons of the test, do PSA, do ultrasonography of the prostate, do CT scan of the abdomen. All right, so we are having majority with B and some with C. So the first option is a very ambiguous option. Tell him about the pros and cons of the test. Which test? They haven't mentioned any name of the test. AMC exam is very literal, guys. They will, if they have written something, they mean it. So what test they are talking about, we don't know. So this is not a correct option. CT scan of the abdomen just for moderately enlarged prostate is only indicated if on DRE you have found some sign and symptoms associated with the malignancy. So that is this imaging is required at that point. So we haven't found any symptoms relating to that. Ultrasonography of the prostate will be done, but the first thing is that we will need to check the PSA level to see if the patient is having any infection or there might be signs and symptoms of the benign prostatic hyperplasia. So the first thing is that we do the PSA levels, and then we go for imaging if we are suspecting something other than normal going on, especially if you want to rule out any malignancies. PSA also guides in ruling out malignancy, but it is non-specific, but it does guide us to see whether the patient might be having any malignancy, any infection, or benign prostatic hyperplasia. So you guys can go over here in the RSCGP guideline link. Dr. Devi, we do PSA because we need to find out if the patient is having very high PSA, that might be indicating of some malignancy, or if the patient is having more than normal, that might be indicating of benign prostatic hyperplasia or infection of the prostate. So that is why we do the PSA. If we find on DRE, the prostate is enlarged. All right, so they have talked about the benign prostatic hyperplasia over here. It's most common benign tumor in men. Although men with BPH often need medical or surgical management from a urologist, but at the time of the disease, they are initially managed by the general practitioner. Yes, it is checked in blood. All right, so where it is. So differential diagnosis for the lower urinary tract symptoms. The patient was having lower urinary tract symptoms like urgency, urinary obstruction. If they haven't given you any clues whether the DRE was done or not, then there should be differentials in your mind regarding the differences for the lower urinary tract symptoms. Like if it is a benign and neoplastic condition of the lower urinary tract, it can be infection, can be caused by infection of the prostate, it can be caused by stones, it can be caused by strictures, overactive bladder syndrome, prostate cancer, or bladder cancers, right? Now, lower urinary tract symptoms can be caused by neurological conditions like Parkinson's, stroke, multiple sclerosis, cerebral atrophy, head injury, spinal cord injury, or pelvic surgery, or it can be from other causes like polyuria from renal or cardiac dysfunction, sleep apnea, and some medications. So very important is the International Prostate Symptom Score, right? Which is whether the patient is having incomplete emptying or not, how much is the frequency, how often patient is having intermittency, is the urgency there or not, is the patient complaining of a weak stream, if the patient had to strain while emptying the bladder, if there is nocturia. So it tells us about whether or not the lower urinary tract symptoms are obstructing the patient's life. So after that, we do a digital rectal examination. Very, very important. Now, coming back to our question, if they have given you in the option, do a urine analysis first in option E, because there are 5 options. No, you don't need to remember the scoring system. You just need to know what symptoms are there in the scoring system. Okay, Dr. Roha? So guys, if in option E, they have given you urine analysis or urine culture and sensitivity, please select that option, because we want to rule out if the patient is having any infection of the bladder or any infection of the prostate that is causing the prostate to be a bit enlarged. Okay. So the first thing that you will do after you have found out the patient is having low urinary tract symptoms is urine analysis, all right, to exclude any signs of infection and follow it up with urine culture if necessary. Then you can also do RFTs, renal function test, if they haven't given you an enlarged prostate. Then you can do RFTs to see if there is any renal impairment or not. You can do urinary tract ultrasound if your urine analysis is showing hematuria. Prostate-specific antigen, controversial is there, but most guidelines do suggest that if you're having DRE and it's showing an enlarged prostate, you need to do it to exclude the cancer. So that is over here. Now for the BPH, what we do is start with the lifestyle modification, pelvic floor exercises, behavioral modification, and then we do the medical therapy with the alpha adrenoceptor antagonist and combine it later if it is not working with the 5 alpha reductase inhibitors. All right, guys, I hope it's clear from here. How do we go from the lower urinary tract symptoms? And if it is a prostate enlargement, we need to do a PSA to rule out the cancer. Is it clear? So if they have given you in option E, urine culture and sensitivity, urine analysis, please select that, because that is the first thing that we do in order to rule out infection, in order to rule out hematuria associated with it. It will give us a clear indication how to proceed further on. Okay. All right. All right. Next question. 85-year-old came to the GP clinic with the complaints of problems with the recent memory. and location impairment. Location impairment means the patient gets lost, doesn't remember where he or she is. The mini mental state examination was done and the score was 23 by 30. What to tell her now regarding her problem? Option A, it is age-related. Option B, it's early Alzheimer. Option C, it's frontotemporal dementia. Option D, it's a vascular dementia. Option E, it's pseudodementia. All right, so we are between A and B, right? Let's discuss each option first and then all right, so let's discuss each option. So option B says early Alzheimer. This patient is 85 years old. So 85 years old is not the age of onset of Alzheimer, mostly because Alzheimer happens in mid 40s and early 50s, right? It happens in young people, not very elderly people. So that is not a correct option. Option C is frontotemporal dementia, the type of frontotemporal dementia in which the person's personality and behavior changes. So personality will be changed and behavior will be changed. Here, the patient is just having dementia, so this is less likely to be frontotemporal dementia. The option D states that it's vascular dementia. They haven't mentioned anything regarding the risk factors for a patient having vascular dementia, like high blood pressure, a previous history of stroke or TIA, a previous history of cardiovascular event. They haven't mentioned anything of that sort, so less likely to be vascular dementia. Pseudo dementia is a term that we use for patients who are going through major depressive disorder, and because of the illness and no response to the treatment, they kind of develop dementia, but it's not actually dementia. It's because of the depression they are having dementia. So this patient is having MMSE of 23. 23 MMSE is not a bad MMSE. It's a good MMSE. It's almost normal. So this patient is having senile dementia, age-related dementia. Is it clear, guys, how we came to option A? So this is age-related. They haven't meant the patient is just having recent memory problems and location impairment and 85 years old with MMSE of 23. 23 is not a bad MMSE. If it was less than 18 or it was less than 20, then we would be very much concerned that it might be some underlying pathology that is going on and causing the dementia, or is the senile dementia very much further progressed. Frontotemporal dementia, personality disorders will be there. Like patient was a very calm and cool patient, and then suddenly very agitated, very out of sort. He was behaving very awkwardly in the society, doing exhibitions or sexually liberating in the community. It will be like that. Yes, MMSE less than 20 is worrisome. Less than 18 is very, very worrisome. Age is related to early dementia. So after 65, it's early dementia does start in some people. All right, after 65, people tend to forget things. Early Alzheimer, early Alzheimer will be in young patients, will be in 40s and 50s. All right, and they will be having problems with recent memory. They will be having problems with They will be having good long-term memory. They will be having problems with recalling the names of the family. They might have some incident happen at home that they forgot the stove, closing the stove, or they might have left open, something like that they might have done. So that is early Alzheimer's. And Alzheimer's will have pseudodementia, Dr. Dave. It's if a patient is having depression, right, and not responding to or not taking any kind of treatment, then because of the depression, they start forgetting things. That is pseudodementia. It is not an actual dementia. It is brought on by severe depression the patient is facing. And it is reversible. Yes, it is related to depression and it is reversible. Once the depression gets better, the dementia gets better. All right. Okay, so let's look at the sources I have here. Okay, this is the RACGP guideline as well as the ELS guideline. This is also one of the websites in Australia that is very well read out. Okay, so what is dementia? Dementia is a general term for loss of memory, language, problem solving, and other thinking abilities that are severe enough to interfere with the patient's daily life. Alzheimer's is the most common cause of dementia. All right. Okay. Okay, it's an umbrella term. Or what other causes? Alzheimer's, most common. Vascular, Lewy body dementia, frontotemporal dementia, and other dementias like Huntington's disease and mixed dementias. So in Alzheimer's, there will be early changes and changes in thinking skills, which is cognitive abilities, severe enough to impair daily life and independent function. Alzheimer's, 60 to 80% of the cases. Vascular dementia, second most common cause, and it is because of the microscopic bleeding. And patient has risk factors for it, like high blood pressure, hypercholesteremia, previous stroke history, TIAs, things like that. Senile dementia is normal part of the aging. Silent symptoms, short-term memory loss, keeping track of a purse or wallet, paying bills, planning and preparing meals, remembering appointments, traveling out of the neighborhood. All of these things are impaired. Okay, causes we know. It can be caused by depression, which is pseudodementia, guys. Medication side effects can sometimes cause it. Excessive use of alcohol, thyroid problems, and vitamin deficiencies like vitamin B12 can also lead to it. So diagnosis is by a group of team of doctors, especially neurologists, psychiatrists, psychologists, and geriatrician. And you might require CT scan and MRI of the brain after doing the mini mental state examination to check the severity. It's the medications are there to stop the progression of the disease and Alzheimer's, but mostly it's a multidisciplinary team approach that is done. You can also study it from RACGP guideline, but it doesn't have that much well written. So I would suggest you guys to study this topic from JM. JM is John Murtagh. Okay, just give me a minute while it's not opening. Okay, this site is not opening at the moment. Let's see. Hi guys, I don't know why this is not opening. Can you guys hear me? Something wrong with my internet connection at the moment. Just give me a second. Just give me a second. I'm just looking at the problem at the moment. Okay. Um, all right. Can you guys see the screen? Okay. Thank you, Dr. Santri. The site can't reach. I think Google is down. All right, I'll make sure that the site is working in your software. So let's move on to the next topic, okay? All right. I hope the topic is clear to you guys. Any questions you guys might be having in your mind regarding dementia, please let me know in the chat box. All right. Next question. A 35-year-old man came from India. The patient had joint pain, sinusitis, swollen joints. The patient also complained of vesicular eruptions in the arms. You have done investigations and you find the platelet was normal. Which can be the provisional diagnosis of this patient? Option A, reactive arthritis. Option B, gonococcal arthritis. Option C, HIV. Option D, dengue. Very good, everyone. So option B. Option B, gonococcal arthritis. Okay, Dr. Rohan, no worry. If you don't know anything, that's all right. You just need to have a good direction about how to study a topic, and then you will be having enough information to remember and to exclude the causes. So 35-year-old man is having a travel history. So whenever there's a travel history, always think about infectious causes first, okay? That can be transferred. Now, patient is having signs and symptoms of joint pain, tenosynovitis, along with the vesicular eruptions in the arm. The lab investigation showed platelet was normal. So what can be the diagnosis? Now, infectious disease in a traveler can be diseases like dengue, malaria, if the patient is having fever. It can be infection of the of the tummy itself, which is gastroenteritis, or traveler's diarrhea. It can be a sexually transmitted illness as well. So here, patient is most likely having a sexually transmitted illness exhibiting as gonococcal arthritis, because vesicular eruptions on the body is pathognomic of gonorrhea, right? Now, why not reactive arthritis? Reactive arthritis is also caused by sexually transmitted infection of chlamydia, but in reactive arthritis, instead of having vesicular eruptions, patients have conjunctivitis. Patient is having mouth ulcers. In HIV, which is also one of the sexually transmitted infection, patient complains of acute diarrhea, rash all over the body, cervical lymphadenopathy or all over the body lymphadenopathy, mouth ulcers is there, and other opportunistic infection can also happen, but acute illness presents like this. Okay, so none of the symptoms of HIV fit this patient. Then, sorry about that. That was my son making noise. So dengue, whenever you think about dengue, you should have in mind the patient should have traveled from a country where dengue is very endemic. Number two, you should know the traveler is having fever, high-grade fever will be there in dengue. And the traveler is complaining of bone-breaking fever, like severe aches and pains all over the body. And the traveler also complains of retroorbital pain or pain behind the eyes. If dengue is not treated, it might lead to dengue hemorrhagic fever, which is the very severe and lethal complication in which patients' platelets go down and patient go into DIC and start bleeding. So very important that you remember that. Okay. So gonococcal arthritis. Possible pathogenesis, it's because of the gonococcal IG complexes deposition in the circulation. Risk factors is it's an infection by the Neisseria gonorrhea, which is a sexually transmitted infection, very common in people who are sexually active, and travel history does indicate that. Complement deficiency, meaning immunocompromised patients can also get that. In patients with SLE, female, menstruating female, pregnancy, low socioeconomic and educational status, these are the risk factors. Now, what kind of joint pain or arthritis is there in? It's a polyarticular asymmetric migratory arthralgia. I know it's big words. Now, polyarticular means multiple joints are involved. Asymmetric means it doesn't have to be on the same side of the body, meaning like bilateral wrist pain is not going to be there. It will be asymmetric. Migratory means it will travel all over the body. It might be in the wrist, then it will go in the elbow, then it will go in the knees. So especially it starts in the upper extremity, and tenosynovitis means inflammation of the synovial sheath around the tendons will be there. So ankle, toes, wrist, the tendons will be hurting a lot. Dermatitis will be there, like vesicular lesions will be there on the trunk or upper extremities, or maculopapular pustular lesions will be there. Sometimes it can cause purulent arthritis, but that is a complication. We diagnose by doing the gram staining of the gram negative diplococci and culture of it, and treating with the help of antibiotics. Now, this picture is very good depiction of what reactive arthritis is. So reactive arthritis happens because of the sexually transmitted infection of chlamydia that is untreated. It can cause inflammatory monoarthritis. It can cause anterior uveitis along with conjunctivitis. So we do PCR examination of the first passed urine or high vaginal swab for it, okay? That is diagnosis. And what we do for treatment, or in the reactive arthritis, we take the aspirate from the joint. And how do we treat it? We give antibiotics. We give doxycycline or azithromycin. Is it clear, guys? All right. Okay. Next question. Can you please describe dengue fever again? All right, so Dr. Kubra, dengue fever is caused by a bite from a female mosquito, and it's a viral infection. It's very common in the Asian countries, especially Pakistan, India, Bangladesh, all right, tropical areas. It's also very common. What happens is that there will be high-grade fever in a patient who has traveled to these areas. Also, patient will have aches and pains, the bone-breaking fever, it's known as. There will be aches and pains all over the body. There will be retroorbital pain as well. And if it is not treated, it can cause low platelets in the body, leading to hemorrhagic fever, in which there will be bleeding all over the body from the eyes, nose, ears, as the patient is going into disseminated in DIC, disseminated intravascular coagulation. All right. So very important differential in a patient who has traveled and coming back to the country with fever. No worries. All right. Next question, guys. A boy, 13-year-old, was brought to the GP clinic by the father with the complaints of knee pain. All examination is normal, except there is tenderness over the tibial tuberosity. The range of movements are normal. What is your provisional diagnosis? Option A, traction apophysitis. Option B, prepatellar bursitis. Option D, C, patellar tendonitis. Option D, transient tenosynovitis. All right, so we have A, B, and C. All right. No worries, we will discuss each option and then we'll come to the conclusion what is the actual answer. So traction apophysitis, it's also known as Osgood-Schlatter syndrome, in which because of continuous traction, there is production of tenderness and nodules over the tibial tuberosity area. It's very common in growing young ones, especially 13 to 14, involved in activities. And patient complains of pain in that area, especially when they have to use their knees. That is traction apophysitis, right? Other one is, all of these happen in athletes. Other one is prepatellar bursitis. So just above the patella, there is a bursa. If it gets inflamed because of some direct trauma or overuse, it causes pain and severe swelling in that area. And in prepatellar bursitis, range of movement is decreased because of the severe swelling and pain. Patellar tendonitis is the inflammation of the patellar tendon, and it is just above the tibial tuberosity, not at or over the tibial tuberosity. Sign and symptoms will be pain while moving. There will be restriction of the range of the movement. Transient tenosynovitis is the inflammation of the synovial membrane of the joint after an upper respiratory tract infection in young people, especially 4 to 8 years old. So now you guys tell me which one is the correct option here. Very good. So it's option A, which is Osgood-Schlatter syndrome. So I have given all the links over here. Let's study Osgood-Schlatter syndrome from Better Health. Hopefully it will open. Oh, thank you. I can't reach this page. Why? Just give me a minute, guys. My sites are not being open. It's not opening at the moment. Just give me a minute. It seems to happen. I'll mute myself.
Hello, guys. Sorry, I'm having thunderstorm here at Queensland at the moment. So I got very bad disturbance in my internet connection. Can you guys hear me? I'm really, really sorry about that. Oh, thank you so much. Thank you for bearing with me. Hopefully we'll... Okay, everything is working now. All right. So are you guys able to see Osgood-Schlattler syndrome on Better Health? Yes, thank you so much, Dr. Hoahead, Jazz, Dr. Sankvi. All right, so it's a painful knee condition that affects the adolescents. During a growth spurt, it is thought that the tendon, which is attaching the quadriceps muscle to the knee joint, it becomes tighter, creating a strain on the growing bone, which is the tibial tuberosity, especially with the physical activities that involve the contraction of the quadriceps. So it usually resolves by itself, but it might require PRICE, which is P is for pain relief, rest, ice, compression, elevation. So this is what it requires. What are the symptoms? Pain in one and both knees, pain when straightening the knee, pain on running or going up and down the stairs, pain that eases with the rest, a swollen tibial tuberosity, especially when you bend down on the knees, a red inflamed skin over it, and quadricep muscle sometimes lose the skin strength and bulk. Risk factors, the risk of fracture of the tibial tuberosity with an unresolved and untreated Osgood-Schlattler syndrome is very high, which is the partial avulsion fracture. Causes we know: excessive exercise, growth spurt in boys, sometimes injuries also there. Clinical diagnosis, treatment is that we do activity modification, which is we ask the patient to take rest from the physical activity that is aggravating the condition. Ice packs, stretching and strengthening exercises, very, very important. We do get help from a physiotherapist, and we do strengthening exercises for the quadriceps and do stretching exercises so that it doesn't cause strain on the tibial tuberosity. Medication sometimes required, very rarely surgery is there. All right, other thing is patellar tendinitis. So Hopkins medicine, American, but very well written. That's why I'm putting it here. It's also known as jumper's knee. Patellar tendinitis, so this is the patellar tendon. So if you look over here, this is the patella, this is the tendon, and it's attached to the tibial tuberosity. So it's the inflammation of this tendon, and it connects the patella to the shin bone, and it weakens the tendon. If it is untreated, it can lead to tear of it. What causes it? Excessive use, frequent jumping on hard surfaces. Symptoms: pain will be around the patellar tendon, not over the tibial tuberosity. There will be swelling, pain with jumping, especially jumping, running, walking, pain when bending and straightening your knee, very, very important. Tenderness behind the lower part of your kneecap, okay, not over the tibial tuberosity. It's clinical diagnosis, but you might need to do X-ray to see whether there is any bone fracture involved or not. Same treatment, PRICE, painkillers, rest, ice packs, compression, elevation, stretching and strengthening exercises. Other one is the pre-patellar bursitis. So pre-patellar bursitis, there is a bursa just above the knee patella that helps to protect the patella from frictional diseases. So it's the inflammation of this bursa. It's by constant kneeling. So in patient, they will give you clues in the examination, like the patient is a plumber, roofer, carpet layer, coal miner, or a gardener. Sometimes direct trauma can also cause it, or it can be caused by bacterial infection. So there is severe swelling. The bursa gets very much inflamed. It looks like this, like a ball. So pain with activity, rapid swelling in front of the kneecap, tenderness and very warm to touch, and can produce a lot of fluid. So you just need to do physical examination, might require X-ray and aspiration of the fluid to check if there is infection going on or not. Treatment is activity modification. Again, rice is there. And if it is an infection, we need to give the patient antibiotics. If these rice is not working, we can give the patient injection of the steroid inside the bursa to help calm down the inflammation. Okay. So I hope all of this is clear to you guys. Let's move on to the next question. A man comes for refugee camp health screen. He has taken 1 dose of albendazole before coming. On lab investigation, he has eosinophilia, sorry, it's a tongue twister. There is no other abnormality. They haven't mentioned about any bowel symptoms. So this is a recaller who is telling us that they haven't mentioned anything about the bowel symptoms. What do you want to do next for investigation to reach the diagnosis? Option A, check ova in the stool. Option 2, do skin prick test. Option C, do endoscopy. Option D, do blood test again. So this man is coming to the refugee camp health screen and he has taken 1 dose of albendazole. That is antiparasitic. Lab investigation shows eosinophils are very high. There are no other symptoms and signs mentioned. Now, what is the next thing you want to do? Excellent, everyone. You want to check for infestation of parasites in the gut by doing stool examination. For checking for ova in the stool is the next thing to do. Why we are not doing skin prick test? Because the patient has taken 1 dose of albendazole and it's a refugee coming for health screening. Allergy is very less likely in this patient. So that is why we're not doing a skin prick test. Similar is the case for endoscopy. If you're thinking about eosinophilic esophagitis, they might have mentioned food allergies or something stucking in the patient's throat, but nothing have been mentioned of that sort. Doing a blood test again isn't going to change eosinophilic level. So that is irrelevant here, and we don't do irrelevant investigation. So the relevant one would be to check the stool for ova. All right, so this is refugee health guideline in Australia. So let me just move just to the point. Okay. Investigations that we want to do. Screening investigation for conditions of high prevalence should be offered to all patients according to their individualized risk as recommended. Make sure that you have informed consent and that you offer STI screening in confidentiality. So what sort of initial investigation should be done for people with the refugee background? Number 1 is the full blood examination. Number 2 is the hepatitis B serology. Number 3 is the hepatitis C serology. Number 5 is the HIV. Number 6 is the TB. Number 7 is the varicella serology. If the patient is more than 14. In women of childbearing age, we do rubella screening. In patients more than 35 years with high-risk ethnicity, we do HbA1c to rule out diabetes, fasting lipids as well. In all women and children, we do ferritin levels. We check vitamin D, calcium phosphate, alkaline phosphate in children, vitamin B12 in less than 6 months vegan, syphilis serology or all the rest of the STIs in all of them or minors, first pass urine for gonorrhea and chlamydia, and Helicobacter pylori stool antigen or breath test if the patient is complaining of upper GI symptoms, and stool microscopy for ova. Look at what they have written forward. If no pre-documented pre-departure albendazole, or if the patient is having persistent eosinophilia after albendazole's treatment, then you should consider going for stool microscopy. Is it clear, guys, why we are doing the stool microscopy here now? Okay. All right. Next, A middle-aged female presented to the GP clinic with complaints of right hand, thumb, and index finger weakness. It gets improved when the arm is raised above the head. There is also mild thenar muscle wasting. Brachioradialis jerk is lesser in power. What is the provisional diagnosis in this middle-aged female? Option A, cervical reticulopathy. Option B, carpal tunnel syndrome. Option C, thoracic outlet obstruction. Option D, cubital tunnel syndrome. Option E, Pankos tumor. So this middle-aged female is presenting with right hand, thumb, and index finger weakness. So these are the motor signs. Gets improved when raised above the head, and also mild thenar muscle wasting. And there is a reflex which is lesser, which is brachioradialis. So what is your diagnosis? All right, so I'm getting A and B. Let's discuss it one by one and see what is the answer here. So let's start with the cervical reticulopathy. Cervical reticulopathy is a condition in which the cervical nerves gets compressed and it leads to motor and sensory deficiencies in the upper limb. So if it is compressing a particular set of spinal nerves, especially C5, C6, C7, C8, then you will see motor deficiencies in the distribution of these nerves. This is known as cervical reticulopathy. And they will mostly have, I think they will mostly have lower motor neuron signs instead of upper motor neuron. Carpal tunnel syndrome is a condition in which there is the flexor retinaculum compresses the median nerve passing through it. So if you look over here, in the images, all right, that's the best image over here. This one. So if you look over here, guys, this is the flexor retinaculum, and under it, the median nerve passes and supplies the thumb, index finger, middle finger, and the lateral half of the ring finger. All right. So in carpal tunnel syndrome, patient will complain of pain, tingling, numbness in the distribution of the median nerve, and also wasting of the thenar eminence, right? Our patient is having weakness of index finger and thumb, mild thenar muscle, but there is no sensory loss. So it can't be carpal tunnel syndrome, okay? Other one is thoracic outlet obstruction. Thoracic outlet obstruction is a condition in which something is going on in the thoracic outlet that is obstructing the veins, nerves, and arteries passing through it. So we just have neurological symptoms. We don't have any venous or arterial symptom here. So this is less likely going to be the answer. Option D is cubital tunnel syndrome. Just like carpal tunnel syndrome, we have a cubital tunnel on the back side of our elbow. And through it, ulnar nerve pass. And it will this is the cubital tunnel, right? Just on the medial side of the elbow, there is a flexor retinaculum through which the ulnar nerve pass. And due to compression of the ulnar nerve, there will be pain and tingling and numbness sensation in the ulnar nerve distribution, which is the little finger and medial half of the ring finger. There is no such thing like that in our question, so less likely going to be the answer. Now, Pankos tumor. Pankos tumor is the apex of the lung tumor. Okay, so when there is Pancreas tumor, apex of the lung tumor. Look at this diagram. So this is the pancreas tumor. It has many symptoms. So what it does is compress the brachial plexus. It also compresses the sympathetic nervous system that can cause Horner syndrome. It causes weakness or paralysis of the recurrent laryngeal nerve as well. So voice problems will be there. And it interferes with the blood vessels as well. Also, it will affect the brachial plexus, which is supplying the hand and the arm. So you will have features of the either a claw hand, all right, things like that, depending upon which root is being compressed. So according to my explanation, now what can be the answer here? So very good. It's option A. This is cervical radiculopathy because the patient's improvement of the symptoms with the raising of the arm indicate that the compression in the neck gets improved with movement. And there is only motor weakness along with the reflexes problem. This is most likely cervical radiculopathy. So what is the difference between cervical radiculopathy and myelopathy? So it's a lower motor neuron signs, right? It's a compression of the spinal nerves just emerging from the spinal cord. There will be muscle weakness, muscle tone will be decreased, atrophy will be there, loss of the reflexes or lesser reflexes will be there along with fasciculation. Whereas myelopathy means compression of the spinal cord at a certain level. So because of the degeneration of the bones in the spine, it can also cause compression of the spinal cord as well. So it will lead to presentation of upper motor neuron signs at that particular level, like hypertonia, hyperreflexia, loss of proprioceptions, different sensory levels in the trunk. All right. So if you look over here, these are the radiculopathies. If it is C4, C5 level, then C5 will be affected and there will be weakness of the deltoid muscles, supraspinatus, infraspinatus. Pain will be along the lateral upper part of the arm to elbow. Sensory loss will be in the late upper arm. So you need to remember all of these, guys. Very, very important for your exam. I can't emphasize it enough how important this is for your exam. So study this table very, very well whenever you are preparing for your exam. Any question, guys? All right. Next question. A patient is on atorvastatin. They have myositis. CK and CRP level are normal. The patient was stopped to take atorvastatin and the lipid profile was repeated in which the triglyceride level is still rising. Which drug you want to start again in this patient? Option A, no restarting the atorvastatin. Option B, pravastatin. Option C, nicotinic acid. Option D, exenatide. So a patient is on statin and they have statin-induced myositis, but CK and CRP levels are normal. And you have done lipid profile, the triglyceride are still very high. Which drug do you want to start again in this patient? This is a tricky one and a difficult question. Okay, Dr. Ruqayya Alam says exenatide. It's actually exenatide, not zematide. All right, I know this is a tricky question, so let's just go towards the topic first, and then we'll come back to the question. Let me increase the size of the screen so that you'll be able to see better. So if a patient has suspected statin-associated muscle symptoms, you need to check the CK levels, right? CK levels, if they are less than 5, then you need to cease the statin drugs for at least 2 to 4 weeks. If the CK level is more than 5, or if the CK elevation is with the muscle weakness, then you need to cease the statin drug for at least 6 to 8 weeks until the CK levels are within the normal range. If with the normal CK level or less CK level, and after ceasing the statin drugs for 4 weeks, symptoms still continue, then we need to investigate for other causes of muscle inflammation symptoms and resume the statin which has caused muscle symptoms. Like if it was atorvastatin, we can continue the same atorvastatin and aim for the target to be of the TGs and LDL to be less. If with the statin, the CK levels are high and patient is going into rhabdomyolysis, we need to stop it for at least 6 to 8 weeks until CK normals are within the normal range. If symptoms improve, then we resume the original statin which has caused this condition, or we can switch to another statin. If symptoms reoccur and the CK levels are again high, then you stop the statin which has caused this symptom again until the CK levels are normal and switch to low dose statin drugs like rosuvastatin. Or you can treat it alternatively. If again symptoms happen, then you go for ezetimibe. All right. So if CK levels are high or muscle weakness is very pronounced, stop it for 6 to 8 weeks and resume it again, or you can switch to another state. If again symptoms happen, then cease the statin and go to rosuvastatin. If symptoms happen with rosuvastatin, then you need a non-statin lipid-lowering drug, which is ezetimibe. Now, patient has myositis with CK and CR normal, stopped atorvastatin, TG is still raised. What do we want to do? So we want to restart atorvastatin, right? Dr. Sankari, I think you were aiming for that. But A option says no start atorvastatin, so we need an alternative statin. No worries, no need to be sorry. So if this said, if I remove this no, then option A is absolutely right. You can restart the statin which has caused myositis by keeping CK and CRP in your view. But here they have said no rosuvastatin restart, so you need an alternative statin like pravastatin. Ezetimibe is the last resort, which is a non-lipid lowering drug. Oh, sorry, non-statin lipid lowering drug. Okay. All right. Next question, guys. A patient came to the GP clinic with erectile dysfunction. He also has depression, emphysema, hypertension, myocardial infarction, and he's a heavy smoker for more than 40 years and an alcoholic. It's in the PDF, Dr. Roha. You can search for it on the Google as well. Most appropriate initial management for all of the diseases, especially erectile dysfunction, would be which of the following? So patient is having erectile dysfunction, but he's having comorbidities as well. Depression, emphysema, high pressure, infarction, and he's an alcoholic. Especially for all diseases, especially for erectile dysfunction. Option A, sildenafil. Option B, cease smoking. Option D, cease alcohol. Option D, increase dose of hypertension drug. Option E, stop perindopril. Very good, everyone. So for erectile dysfunction and for all of the diseases the patient is having, Cessation of smoking is going to have a very beneficial effect on the health and will decrease the likelihood of him having a myocardial infarction or stroke again by 15 to 25%. Sildenafil is not the first drug of choice for erectile dysfunction. Alcohol sees, if they said sees alcohol and smoking both, it is going to have a good effect on or as an initial management. Increasing the dose of high blood pressure, even though the blood pressure is controlled, is not a good option here. Why would you want to stop high blood pressure medication in a patient who has already been diagnosed with it? So stopping penidopril is not a good option here. Okay, so there is this guideline RSCGP. There is a table that I want you to see. Okay, the treatment. Stepwise approach to erectile dysfunction treatment, right? Initiate the discussion about it. You need to be very open with the patient and can be very respectful of their personal beliefs as well. Define the problem, whether erectile dysfunction is happening because of some psychological problem, because of some medication, because of some underlying disease, or it can be because of some sexual problem. Take good history. Take blood pressure, body mass index, weight circumference, do a proper genitalia examination. You need to do blood test as well. You need to check for the morning testosterone level, HbA1c, lipid panel. Now, the first treatment option is lifestyle modification. Smoking cessation, healthy diet, exercise, reduction in the alcohol, and avoiding of the recreational drug. Reinforce blood pressure, dyslipidemia, and good diabetic control. Assessing for cardiovascular disease, it's going to optimize the patient's health. Then treat the reversible causes. If there is low testosterone, you can treat it. If it is medication-induced erectile dysfunction, you can treat it. If it is psychogenic, then you can give the patient cognitive behavioral therapy for it. If none of these are working, then you can start with the pharmacological therapies. And if the pharmacological therapies are not working, you can refer the patient for a urologist or other treatment options which are available. All right. Next one is an ethics question. A university student presented for SIX certificate that he missed an exam yesterday because of muscle aches, headaches, and fever, starting last 3 days. He's now well. What will you do as a GP? Decline the request as his illness is not confirmed. Decline the request as he is not present during the exam day. Confirm his illness from the third party and give him the certificate. Date the certificate with today date, dating the certificate with the exam date. So what do you guys think? So we have a couple of options with A and I think one option with B. So guys, this university student is coming to the GP for SIX certificate because he missed an exam and there are no signs and symptoms of him having an illness right now. So this is a very high chance that this student is factitious. Sorry, he's malingering. Sorry, wrong choice of word. So we will decline his request as his illness is not confirmed. If the patient is having any slight signs of illness, like there is upper respiratory tract infection symptoms still there, and patient is still complaining of some fever and headache, then you will definitely give the datings, the SIX certificate with the today date for the last 3 days. But if you think that there's some suspicion that this might be malingering, then you have every right to decline the SIX certificate. Yes, very good, doctor. Must decline politely but firmly. All right, another question. A lady was taking olanzapine and was stable with that. But sometime later, she complains about weight gain. BMI is 40. Which one of the following you have to give her now? So she's taking an antipsychotic, olanzapine, and she is having the most common side effect associated with it, which is weight gain. Now her BMI is 40 and we don't want her to gain more weight. What other antipsychotic you can give her? Option A, risperidone. Option B, clozapine. Option C, aripiprazole. Option D, quetiapine. Option E, haloperidol. So we have A, B, D as an option, or A or D. Okay, so let's discuss it. Now, guys, antipsychotics have some side effects, and most of them are pretty serious, but weight gain and dyslipidemias is also one of them. So let's see which antipsychotics are associated with high weight gain and dyslipidemia and which are not. So olanzapine the patient was already taking, so it has a high risk of weight gain. We had clozapine in the option as well. It has a high risk of causing weight gain, so we won't give this. Chlorpromazine, high rate risk. Quetiapine, risperidone, paliperidone, they have medium risk. So not a good option. If they have given you acinapine, amisulpiride, aripiprazole, lurasidone, ziprasidone, they have low risk. Why we are not giving haloperidol here? Because this is not a good choice in a patient who has already been given second generation antipsychotic, even though it has a low chance of causing weight gain. So here the answer will be aripiprazole. Is it clear, guys? So risperidone, quetiapine, they have medium risk. Clozapine has high risk along with olanzapine. Haloperidol, aripiprazole, acinapine, ziprasidone, they have low risk, but we don't give haloperidol in a patient who has second generation antipsychotics in them. It has more extrapyramidal side effects, which we want to avoid. So aripiprazole has very less weight gain risk as well as extrapyramidal side effects. So this is the best option among them. All right, any question, guys? Okay, a patient is coming to you with intense photophobia and painful red eye, but pupils are reacting to light normally. What is your provisional diagnosis? Option A, keratitis. Option B, glaucoma. Option C, foreign body. Option D, conjunctivitis. So excellent. The patient is having intense photophobia, painful red eye, but pupils. No, Dr. R, you will not be getting 2 lines in the exam because in the exam, they will give you the whole scenario. Okay? They will give you a whole scenario with more information. So no, you will not be having just this information. Okay? All right, so this was a pretty easy one. I would recommend you guys to study all of the eye diseases from the RACGP guideline. There is a whole table. You guys can study the whole table over here. So if you look over here, subconjunctival hemorrhage, nasolacrimal duct obstruction, dry eye, episcleritis, clasion, blepharitis, viral conjunctivitis, herpes, keratitis, corneal foreign body, bacterial conjunctivitis, dye, allergic conjunctivitis, blunt trauma, uveitis, marginal keratitis, corneal abrasion, preseptal cellulitis, scleritis, acute glaucoma, chemical injury, penetrating eye injury, microbial keratitis, endophthalmitis, orbital cellulitis, decrocystis. All of them are given over here. So you guys can easily study it from this guideline. I would really recommend you to go through this. All right, next question. Okay, we have cerebrospinal fluid. You can get it after enrolling in the course. You have access to all of the questions till 2019 in the course software. I don't know anywhere else where you can get such a compiled course. Okay, in the course, you can go towards the previous questions in your software. So you can find it over there. All right, so cerebrospinal fluid has been given. Glucose is normal. Polymorph nucleosides are high. What antibiotic of choice you will give to the patient? Option A, ceftriaxone. Option B, ampicillin. Option C, gentamicin. Option D, acyclovir. So can anyone tell me what is the CSF finding indicating? The CSF findings is indicating what sort of disease? Bacterial infection. Very good, Dr. Binita. So what sort of antibiotic do you give in a CSF bacterial infection? What is the first line drug that you give? We give ceftriaxone. Ceftriaxone is the first line drug in bacterial meningitis. Okay. Penicillin can be given, but it's not a first choice drug. Ceftriaxone is the first drug of choice. We don't give gentamicin. We give acyclovir in the viral one. We give benzyl penicillin in children who are less than 2 months of age and having bacterial meningitis. So if you look over here, in bacterial CSF findings of the infection, there will be increased opening pressure, whereas in viral, fungal, and tuberculosis, it will be usually normal. White blood cell, it is normal sometimes, and it is decreased as well. It can be normal, it can be decreased, both can happen. You have to look at what type of cells are there and what is the white blood cell count. If it is polymorph, then it's most likely bacterial. If it is less than, if white cell count is not high, but the cells are lymphocytes, then it's viral and fungal as well. Okay. Protein level is high in bacterial, fungal, and tuberculosis, but normal to elevated in viral, whereas glucose can be low in bacterial and be normal as well. Okay. So in the bacterial meningitis, according to the RCH guideline, we give ceftriaxone as the first drug of choice. If it is less than 2 months old, we give benzyl penicillin with ceftriaxone. But if it is more than 2 months, we give ceftriaxone or cefotoxime as first drug of choice. Okay, whereas it's not necessary, doctor, that the glucose would be low. It can be normal, it can be low. So in encephalitis, if it is caused by viral illness, we should give acyclovir. All right, next question. If you look over here in the table, normal to marked decrease, they have written. So it can be either of those, not necessarily it is low. That is not a hard and fast rule. All right, next question. A patient 6 years old presents to the emergency department with dyspnea and biphasic stridor. Now the patient's vital signs are stable. What do you want to do next after the chest radiography? Option A, intubate the patient. Option B, do the chest radiography again. Option C, neck lateral X-ray. Option D, ABGs. Very good, everyone. So what are you trying to look for in the neck lateral X-ray? What are you trying to find? Your answer is absolutely right. Any obstruction to the upper airway, right? Any obstruction to the upper airway, we are looking for that. What is causing the stridor, biphasic stridor, why it's happening, and we are looking for any obstruction. So that is why we are doing the neck lateral X-ray. Excellent. If the vital signs were not stable, we will intubate first and then go towards the imaging. Make sure that you follow the primary survey protocol, which is airway breathing circulation. So when there's acute upper airway obstruction, we need to do a couple of investigations. Like if the patient is having moderate to severe, then you need to secure the airway and delay the investigation. X-ray of the chest and soft tissues of the neck will be done, or CT may be required. Okay, so neck lateral X-ray can help you to find out the cause of the obstruction and cause of the biphasic stridor. Very good. All right, next question. A young male, 24 years of age, presented to the emergency department with chest pain, which is now better. Chest X-ray, pneumothorax is 15%. What do you want to do next? Admit and observe the patient. Ask the patient to come back the next day. Do needle aspiration. Do chest intubation. So we have A and C. Okay. So guys, there is a rule in how we treat the pneumothorax, right? Symptomatic and asymptomatic. Patient was symptomatic, but now is asymptomatic. On chest X-ray, there is pneumothorax of 15%. In asymptomatic patient, we admit and observe, right? But if it is more than 15% and patient is asymptomatic, we do needle aspiration. If patient is symptomatic, then we do needle aspiration, regardless of the percentage. Is it clear? So if the patient is asymptomatic and pneumothorax is less than or equal to 15%, we admit and observe with serial X-rays to see if it resolves on its own or not. If the patient is having more than 15% and is asymptomatic, need to do needle aspiration. If the patient is symptomatic, irrespective of percentage, we need to do the needle aspiration. So you can study it from ACI, New South Wales guideline. Okay, so we know spontaneous pneumothorax can be primary with no cause and secondary with underlying lung diseases, and it has symptoms of chest pain, sudden onset of shortness of breath, sometimes anxiety, cough, and vague chest symptoms. So severe symptoms with signs of cardiopulmonary distress may indicate tension pneumothorax, like patient is having cyanosis, sweating, severe tachypnea, tachycardia. So we need to do immediate needle decompression followed by chest drain. How do we confirm it? We do a bedside ultrasonography and we do a chest X-ray. You don't need to collect all the guidelines. It's already provided in your course, in my class PDFs. You can just go over there and see for yourself. Just click on the link and it will come. So what are the treatment options in the spontaneous pneumothorax? Primary, if it is small without significant breathlessness, observation. If it is a large or a small in patient who is symptomatic, we need to do needle aspiration. Is it clear, guys? Dr. Soprana, when you will be enrolled in the course, we will guide you what to learn and what not to learn. Don't worry about that. I know it seems like a very big task, but as you continue your way through the course, it will become very easier for you to navigate these guidelines, and you will know what to study and what not. At the start, everything seems very difficult, but if you start doing it, you will get the hang of it. All right, so don't worry about it. You just, I always tell all of my students to, whenever you're going through a guide, try to read it whole. Then you will know which points to revise from it. Worries? All right, next question. A GP has cognitive impairment and he is taking treatment for it, but still he is seeing the patients. What do you want to do next? Option A, inform AFRA. Option B, talk to the GP. Option C, inform a principal body. Option D, monitor the activity of the GP. So guys, cognitive impairment is a notifiable offense. All right, you need to notify it to the AFRA. However, this is not the practice, but in MCQ exam, they want to know that you know which are the notifiable offenses, and this is a notifiable one. In youth practice, we don't go to AFRA directly. We talk to the GP, let them know about our concern and ask them to do something about it. But here is, you will select AFRA because these are the mandatory notification. That is impairment, intoxication while practicing, significant departure from accepted profession standards, and sexual misconduct. So impairment is there in the GP. So you will be doing is informing the AFRA. You will not be talking to the GP in the exam. But in real life, you will talk to GP. Okay, this is a literal exam. They want to know whether you know the notifiable, mandatory notifiable offenses or not. Okay. Okay, guys, I hope it's clear. The ethics questions are a bit tricky, but once you go through the guidelines, you will come to know what is to be done and what is not to be done. Don't worry about it. All right. A man came with back pain. There is mild tenderness over the sacroiliac joint. X-ray shows early inflammatory changes. HLA-B27 is positive. HLBA, sorry. Apart from physiotherapy, what else should we give to this patient? Option A, biological agent. Option B, naproxen. Option C, steroid. Option D, sulfasalazine. Option E, paracetamol. So most of you are going with B. Can anyone tell me what is the clinical diagnosis here? Dr. Soprana, what have you thought about? Very good. This is ankylosing spondylitis, and the first line agent that we give is the NSAIDs. Excellent, along with the physiotherapy. Biological agents, steroid, sulfasalazine, these are third line. Paracetamol can be given if the pain is not being controlled by the NSAIDs, but it's the first line drug which is recommended is the NSAID. Okay, the RSCG guideline tells you all about the ankylosing spondylitis. So if we go to the treatment of it, management, first one is exercise and education, which is physiotherapy. And the pharmacological one, NSAIDs are the first line therapy for symptomatic ankylosing spondylitis patient. It reduces and slows the progression of the disease. And if it is not working, then you can use a TNF inhibitor with the NSAID. So what are the things that you need to know? And you can also use DMARDs as well, like methotrexate and sulfasalazine. So TNF agents are especially indicated with the NSAIDs if the patient is having bamboo spine, okay? All right, next question. A young male was brought to the emergency department with snake bite but you have found no fine marks and there's just a linear scar. What do you want to do next? Option A, take swab and pressure bandage. Option B, anti-venom kits should be started. Option C, transfer to the hospital. Option D, serve anti-venom. Very good, guys. So we know that in any case, whether it's a poisonous snake or not, we should apply the pressure immobilization bandage and transfer the patient to the critical area. Same question. A patient presented with the history of snake bite. There are no signs of envenomation, but you can see punched out fanged lesions. He presented 30 minutes after the bite. He is wearing jeans and was bitten through it. What will you do next? Admit and observe and give antivenom at 12 hours. B, discharge. C, give antivenom right away. D, do lab investigation after 24 hours of the bite. So guys, what will be the answer here? Very good. We will admit and observe the patient, apply the pressure immobilization bandage. If signs of envenomation occurs, we can give antivenom at 12 hours. We never discharge these patients. We need to observe them. We don't give antivenom right away unless there are clinical signs of envenomation. Lab investigation are done immediately after the snake bite. So if you look over here, this is from the RCH. If there is history of possible snake bite, then we observe the patient in a critical care area, apply pressure immobilization bandage, if not already done, and look for clinical evidence of envenomation. If there are signs of that, we do the initial resuscitation, which is insert 2 IV white bore cannulas, take blood for investigation, resuscitate the patient, consult with the toxicologist, be prepared for anaphylactic reaction, give antivenom, and release the bandage after antivenom and observe the patient. If there are no signs of envenomation, then we apply the topical anesthetic, insert the IV cannulas, take blood samples, swab the bite site. If there is lab investigation, which is showing signs of envenomation, then we give antivenom. If not, then we release the pressure immobilization site bandage, and we do 6-hourly lab investigation after it. If still no sign, then we discharge the patient in the daylight. So very well done. All right, this is an easy question that came in November exam. A patient is having polycythemia rubra vera. What is the physical examination finding in this patient? Option A, splenomegaly. Option B, cardiomegaly. Option C, purpurias. Option D, opaque eyes. Option E, joint pain. So, excellent, guys. This will be splenomegaly, which is a sign of the polycythemia rubra vera, along with the pinkishness in the body, cyanosis, and a rash over the body. So if you look over here, this picture depicts it very well. Fatigue, headache, dizziness, these are the symptoms. Episodic blurred vision, peripheral tingling, burning and itching, hypertension, mucosal cyanosis, bruises, fatigue, enlarged spleen or liver. We know this is because of the overproduction of the RBCs. It can be because of the increase in the production of the hematopoietic stem cells or increased erythropoietin. It can be primary and secondary. So treatment is we do phlebotomy. We increase the fluid intake because the hyperviscosity of the blood is increased. So there's chances of clotting. We give aspirin to avoid that and myelosuppressive agents to suppress the bone marrow, not to produce large amount of red blood cells. All right. I hope you guys are not tired. Just a few questions left and we will be finished with our question solvation class today. All right, a patient is coming to you, gravida 2 para 1, previous scar for breech under anesthesia. This time she is 39 weeks pregnant, placenta previa has been diagnosed, and she was planned for cesarean section. Otherwise, there was no antenatal problem. Immediate upon the delivery of the baby, patient blood pressure drops to 60/40. There's profuse bleeding and it's not clotting. Pulse rate is also low. She's going into bradycardia, which is severe form of shock. What is the provisional diagnosis? Option A, anaphylaxis to anesthesiologic medication. Option B, amniotic fluid embolism. Option C, retained placenta. Option D, uterine inversion. Option E, extended tear to uterosacral ligament. So you guys are very good in this. I'm very happy to see most of you are responding that clear answers. So this is amniotic fluid embolism, right? It happens immediately or during the delivery of the baby. Amniotic fluid goes into the blood circulation, cause embolism to the brain. So there will be instant shock, profuse bleeding, patient goes into DIC. It's not anaphylaxis because in anaphylaxis there should be urticaria, there should be cardiac collapse along with it. There can be problems with the GI. Nothing of that sort is mentioned, or there can be laryngeal edema or angioedema. Retained placenta is not there because they have said immediate upon the delivery. They haven't mentioned about the delivery of the placenta yet, right? So less likely to be retained placenta. Uterine inversion happens if they are trying to pull the placenta and the uterus get inverted. Less likely. Extended tear to uterosacral ligament. It happens, but it doesn't cause this much of a shock this quickly. It doesn't cause the patient to go into DIC. So most likely our answer is the amniotic fluid embolism. So you can study it from the SA Health guideline over here. Okay. Amniotic fluid embolism, very rare, very, very rare. There are no risk factors. And diagnosis is, there is acute hypotension or cardiac arrest of the patient during the delivery or after the delivery. There is hypoxia and there is coagulopathy. So these are the diagnostic criteria for it, okay? Differential diagnoses include anaphylaxis, aortic dissection, cholesterol embolism, myocardial infarction, pulmonary embolism, and septic shock. Presentation is the same as we have discussed. Patient will go into shock during or immediate after the delivery. Sweating, shivering, anxiety, coughing, followed by respiratory distress, altered mental state, seizure or seizure-like activity, or cardiovascular collapse. And they do have cardiorespiratory arrest with DIC causing extensive damage. So resuscitation is the only way we are going to save the mother. Call for help, do wide bore cannulas, give fluids, give blood, make sure that you ventilate the patient, intubate the patient so that the patient doesn't have a hypoxic injury to the brain, give FFPs to the patient so that DIC can be compensated. Sorry, excuse me. All right, next question. A patient presents to the GP clinic with complaints of diplopia, arthralgia, hematuria, hemoptysis with high blood pressure. What's the diagnosis? Option A, SLE. Option B, Wegener granulomatosis. Option C, Goodpaster syndrome. Option C, polyarthritis nodosa. So I am getting B and C as options, right? So we know for SLE, there should be a diagnostic criteria of 11, including skin manifestations, neurological, hematological, arthralgias, all of that. So in here, the option Wegener granulomatosis is correct. Let's look at this. Wegener granulomatosis is also known as granulomatosis with polyangiitis. It has a classical triad. There will be upper respiratory tract granulomas, nodules, and glomerulonephritis, right? So it happens in elderly. There will be low respiratory tract symptoms. There will be oral ulcers. There will be upper respiratory tract symptoms. There will be eye involvement, joint involvement, kidney involvement, right? So diplopia, hematuria, hemoptysis, hypertension, arthralgias, all are there for granulomatosis to be diagnosed. In good pasture syndrome, there will be just kidney and lung. There will be no arthritis, right? And in polyarthritis nodosa, there will be dermatological appearance will be there, like libido reticulitis, ulcers, subcutaneous nodules, or gangrene, along with high blood pressure, and GI symptoms can be there, and nervous system will be very much involved. That is why that was Wegener granulomatosis. Is it clear, guys? I hope these pictures will help you to make sense of things, because it did help me. So I always put myself in you guys' place. All right. Next thing, and the last question. A patient was brought to the emergency department with a diabetic foot ulcer. What's the next investigation you would do after antibiotics have been given and debridement was done? Option A, Doppler. Option B, venous scintigraphy. Option C, X-ray PET. Option D, MRI. Wow, I'm among very well-educated people over here tonight. Excellent once again. Can anyone tell me the reason why we are doing X-rays after antibiotics and debridement? What are we looking for in the X-rays? Very good. We are looking for signs of osteomyelitis, bone involvement. And if there is some signs, what is the next thing that we do? We do MRI, okay, to see the extension of the osteomyelitis and plan the treatment according to it. So I've taken this from the MDX. Plain radiography is the most common first-line radiological investigation in an acute presentation of diabetic foot ulcer to assess for underlying osteomyelitis. MRI is the best modality for osteomyelitis because it is very sensitive and specific, but it's very expensive. All right. So after doing X-ray, if signs of osteomyelitis are there, then we will move on to MRI for a detailed assessment about the area which is involved, and we can plan the treatment according to it. All right, so thank you so much, guys. This will be all for today. I hope you guys had a good session. And I hope I can be a part of your journey as well to help you meet your dreams of working here in Australia. So if you guys have any further questions regarding the course itself, I would really much advise you to get in contact with Dr. Arshan. It's worth the money if you pass the exam. And we will be helping you guys every step of the way. I always answer the queries during my class and afterwards as well. So does Dr. Arshan. We can help you with the materials. We can help you with what to study, what not to study, and guide you along the way. So thank you so much. I hope to see you guys soon in my course. Thank you so much, Dr. Jennifer. That's so nice of you. I'm happy I was able to help you guys get a little bit of view into what sort of ambiguity is AMC MCQ exam. It's not that much difficult, but with the correct guidance, you guys will be able to crack it. So thank you so much. Have a good night.